My name is Elizabeth Mangru, and I'm one of the local chairs working here at the University of Malmö. I have the honor of introducing our next keynote or plenary speaker, and it's Bengt Arnetz. And Bengt, he is actually working in US, but he comes from Sweden. And he has an MD and a PhD in psychophysiology from Karolinska Institutet in Stockholm in Sweden. But he works currently as a professor in Family and Preventive Medicine at College of Human Medicine at Michigan State University in Michigan in US. And he is focusing on different areas. We will hear about one area here, but you can just summarize that it's like community-based participatory research that addresses biopsychosocial mechanisms that has or is involved in different kind of health disparities and stress-related disorders. So very welcome, and I give the word over to you.
Thank you so much, Liz, for the kind words, and thank you for the invitation. I was thinking, while I was listening to all these presentations, because I was a little bit nervous what I was going to focus on, and it's really inspiring to hear. And at the end of the day, I think it's really about what happens to the brain under different circumstances, from health inequity to nutrition to injustices. But at the end of the day, it's going to affect our brain. And I'm going to focus on the brain, and I'm going to do it from two different perspectives. One perspective is how can you mobilize community-based participatory action to make sure people dare to apply for money they have the right to. So that's called earned income tax credit. A lot of money is there on, in Michigan, can be up to $10,000 per family, but huge amount of families, especially with immigrant background or in an exposed situation, are there to apply for the money because they think they might have implication when it comes to the right to stay in the states, or that they were going to be, they don't really trust the government, they don't trust the local government. And the other one is about air pollution and how that can affect well-being, and also a huge study done together with the community. And we want to be able to do these kind of studies without the community involvement. So that's the two focuses I have. And at the end of the day, I want to try and focus how that can affect the young brain and the implication for long-term health, but also for learning and development, brain development, etc. And the model we're working with is, I focus, as you heard Elizabeth say, on mechanism. How does the environment we live in, psychosocial environment, social determinants of health, but also the real environment, the air pollution, for example, exposure, how does that affect body? So we need to do kind of intervention, right, to really try to understand mechanism, not just look at association, but look at understand the mechanism. So we design studies, and then we try to scale these studies. Are they really realistic? Can you actually do something in a larger scale? But before we can scale it up, we want to see what is the mechanism. So if we think, for example, that air pollution affects inflammatory responses, does an intervention against air pollution then decrease inflammation? And thus, if that works, then we can try it out on a larger scale to really see if it's something we can apply. And my journey has been from, I focus very much on basic cellular mechanisms from the beginning, gene effect, different kind of hormones, etc., up to this health. And then we lately, I would say last maybe 10, 15 years, I reversed. I'm trying to understand society's effect on the gene and how that affects the health. So really working with transdisciplinary teams, sociologists, psychologists, people who engage with the community partners is really important for me. And I'm basically, my focus is just then try to collect kind of different samples from participants and biomarkers. And then we also, it's very important for us in our research to feed back the results. So we always feed back the results, both to the individual and to the group. How are your biological profile, and what might that indicate, and how will we use that to make contribute to changes? So this is, if you look at the brain health, we know this about brain health, that there's structural changes if you look at the brain, there's been changes. There are functional changes. The brain functions differently. And these effects can be around the time of birth or after birth. And we know it's remodeling. The whole brain remodels. And if you're under high stress, even intrauterine, you're going to remodel the brain to be ready to handle stress better, which means the brain is going to be a little bit more ready to deal with stress, right? Which takes energy. But for the body, it's smart because you're ready to survive. You're ready for being attacked. So you trade long-term well-being for survival in the short term. So you're going to see the reward system that really is so important for willing to learn, willing to focus, believing that there's something reward in this is going to change. Executive function changes, language attention changes. So this whole stress biological system shifts the way for the future and focus much more on survival today. It's not so important if you survive tomorrow if you're not going to survive today. And then you have adverse impact on impulse regulation. And there's a lot of research showing how delay reward is going down. So the discounting $1 in the future means less than $1 today, but they discount much faster. So $1 in the future was basically less, much less when you live under stress. So you rather take $1 per day, even if you're going to get $5 tomorrow. So it's a tremendous discount of the value of focus on the future. And then impact. You have neurophysiological effect, cognitive and behavioral effect. You have a stress response pattern that changes. So if you live under a lot of stress, young brain, you're going to see different response to stress when you're exposed. And then intervention, what kind of intervention can we do? We can do decrease stressor, of course. You can decrease the exposure in the community to stress, which we talked a lot about. You can do preventive co-exposures. Is there other exposure, well-being exposure, social determinants of health that you can strengthen, you can be exposed to? For example, we heard this morning about Hela Malmö. Can it be that you, part of all these activities, does that strengthen your resilience to the adverse exposure? You have resiliency strategies. You can work at the community, build up resiliency. What can we do together to deal with exposure, to be more able to handle individual, and you can work with lifestyle. And then, of course, you can do, for example, executive memory training. So all of these things are going on. But the problem is, how do you scale it up on a community level? And I think that's what's so exciting what's going on in Malmö with all these kind of activities, looking at the community level. So first then, before I go into specific study, I think it's really important to think about what is health. And realizing this new definition, it's a state of complete physical, mental, and social well-being, and not merely absence of disease. And there's extremely little research done on wellness, biology of wellness. We do try to do a project trying to understand what is the biology of wellness when you really feel well, not lack of disease, but it's extremely little research done on that part. Everything, our reference is almost, disease. And then how do you look when you have less of the disease? But it's very rare we study the other end. How can you grow wellness? But there's so many aspects, right? And there's so many factors, social determinants, genetics, living condition, nutrition, etc., that contributes to health. And I think it's important to consider that also when you do these kind of studies. So this is just, what kind of aspiration do we have when we do socioecological intervention? What are we really targeting? And we try to target then mechanisms that we think are causing ill health when we do our interventions. And of course, the community is extremely important there. And so starting with mechanism, that's the first step. This is, if you look at the brain, this is the psychosocial stress or socioeconomic stress. It hits the brain. But once the brain is exposed to that, you're also going to react different to psychosocial stress. So it's a two-way communication, right? It's not less that stress affects our brain, but it's going to go the other way too. And with that, you also have the environmental stress here on the left. So if you live in a high air pollution, you're going to have an effect on the brain. So it comes from both ways. And once it's inside the brain interprets this. So how am I going to deal with this stress? And there has a lot of mechanisms. You can deal with the endocrine system, immune system, autonomic system, blood pressure, etc. And then, of course, the body also has to deal with bacteria, trauma and disease and stress-related disorders. So it's a lot of force on the brain or the different kind of system in the biology to deal with stress. And that's why living under stress has such consequences. And I talked before, can you actually create, if you create a more brain healthy environment to grow up in, what is going to be the benefits for impulse control, risk to join gangs, learning, change their view to make it more long-term view of the benefit of investing in your health or in your knowledge, etc. So this is a very simplified model, but it shows how many aspects really influence the system. And socioeconomic factors, up to 2010, we said we just control for socioeconomic factors, right? And a lot of this thing, actually, I was very stimulated by reading articles in your journal in health, wellness, and society. But now we try to understand, okay, socioeconomic stress is just, or socioeconomic factor is just a signal for something. When you start to break that down, you realize it correlates to a lot of concrete risk factors you can do something about. And today is much more contemporary. We need to understand all these factors and try to intervene there to actually change something. So socioeconomic factor has been from something we control. They try to take away from the analysis to something we really need to consider and see how does that interact with other kind of exposure. And this is, if you put the brain, our young brain, into reality, and I talked about this, right? Lack of resources, unemployment, passing the whole density, environmental noise, environmental pollution, etc. It's going to have effect. And then you have parental stress, for example. If you also live in a family where the parents are under a lot of stress for various reasons, you're going to see more child stress. There might be more family conflicts because you have less resources to address challenges. And you might have diminished parenting practice. We heard this morning mentioned that some parents are not aware how to treat, for example, how can you treat, Russ will talk about this, how should you preventively take care of your teeth? If you don't have that knowledge in the family or not awareness of it, that's going to contribute to how the young brain is affected. So it might be child stress, and at the end of the day, all these things, right? Diminished parenting practices, increased family conflict, and child stress are going to affect all these structure in the brain. Everything, amygdala, for example, that makes us ready to fight, see threats, which is really important. We need to know that when are threats real, when do we need to prepare for it? But you're also going to have a lot of effect on other areas, and these are different areas for learning, memory. And hippocampus is really important for learning. And if you have relearning, you're going to see growth in the hippocampus. And we can actually measure, we do another study now, we can measure this in blood if the brain actually responds or not. You can measure certain kind of biomarkers. But also, the maternal education here, how that affects, what's the skills level, and what is the knowledge of the young brain? What can you do within the family to care for the young brain, to stimulate the young brain? So of course, you have to have intervention at the communal level, school, etc. But it also be very, very important the time you spend in the family. So intervention can be focused on intervention targeting parents also, skills level, awareness of this kind of interventions. Okay, and then, so this is a basic model where we try to understand it, and you see the reference there where I got it from. But we start up here, household income to needs ratio, and that's where we intervene in one study. I'm going to come back to that's the first study. We try to intervene at this level, high up in the causal chain. That should affect resource constraint, and that should give more ability to decrease the stress here. And it should decrease parental stress. And by that, you should also see less childhood stress. And at the end of the day, the structure change of the brain, the young brain, should be less in a family with more resources, the way you mobilize more resources than in a community or family where you don't have that. So the intervention is, typically you make intervention rather low down in the causal chain, closer to the biological intervention. But we try to do community intervention affecting this up here. And just show you, this was a study I did way back when I was a PhD student. But this was people who risked unemployment, people who lost their job, and people who have a safe job. And then people who lost the job got an intervention, psychosocial intervention, basically. How can you skills develop yourself to try to get a new job? It was how do you work with your CV? How do you work with your skill sets? How do you present yourself? And we randomized that to half the group who lost the job, another half didn't get it. Despite that, look, immune function, the ability for the immune system to react, you give a special substance to see does the immune system react, and you can see how much more active certain kind of lymphocytes gets. It went on in both groups, regardless. Here's the control group. Regardless if you get the intervention or not, you still see a decrease. And the risk of losing your job, that's another group here, lost their amount just as much. Just being under the threat of losing your job has the same effect as actually losing a job. Because it's this, it's actually less stress knowing what's going to happen than predicting what might happen. That's the worst part. And this, we talked a little about this morning about the resource. This is US dollar adjusted purchasing price, and this is Sweden. And it's around the lowest 10 percentile of the families in Sweden had this average purchasing power in the blue line. And this is the United States. And it's a lot of transfer of money. So now, right now, the lowest 10% in America has more money to the household than this typical Swedish, which has been rather flat. So studying compared, it's very similar now, right? The US and the Swedish system when it comes to the worst, say economically worst exposed family. And the background we heard this morning, this first study is SNAP. But how can you, the idea is how can you create more financial resources in a family? And it started with SNAP that we heard this morning. If you look at SNAP, everybody who qualifies in the States has the right to SNAP. But the problem is people don't use it. And it's a very strong relationship between household characteristics. So only half of eligible Black household apply for it, and then it goes down. So Hispanic 30%, people 65 years and over 30%. So a lot of people, for lack of knowledge or they don't trust the system, don't apply for this money. So even though the money is there and the SNAP is there, people don't use it. But this is a very important, we heard it before in the presentation, very important, nutritional support system. So this is, now I'm going to talk about this specific project. So we got funded together with Access, and I think I have it, here's Access. It was a lot of different organizations, but Access is a huge organization, tremendously community-focused based NGO who works, from the beginning they worked with Arab Americans and they started in Detroit in the 60s, but now they work with all kinds of groups that are challenged when it comes to social success or household insecurity, substance use disorder, to health and to, so they even have their own public health group, and very, very engaged in the community, very trusted. We had different kind of collaborating boards. So together we created this project, and we got funded under this grant that see if it's okay. See if it doesn't work there. Maybe I have to go share. Maybe the battery ran out. Just okay. So
Start it over again.
is that what you have to do?
Is it first?
Maybe froze. Yeah. No, so Health and Human Services in the United States had a department division of minority health, and they funded this project for like 15 centers around the country. So the whole idea is, how can you get more uptake? How can you get families who are eligible?
You want to test that out? The
Yeah.
clicker?
Yeah.
There you go.
Yeah, I can move on there. That's okay. How can you get people to apply? So we mobilized a group from the community, discussed, what kind of activities would go, how can you increase the awareness of this EITC, earned income tax credit? And then how can you actually make people apply? So first we want to increase the awareness in the society, and then we want to make sure people apply. And this is the area we work with. Southeast Detroit, Southeast Michigan, big part of Detroit and suburbs. Huge population of Arab America. This specific intervention was focused only on Arab Americans. And this is in Michigan, you can earn actually up to, depending on income, you need to have some income in the family. This is a pro-employment program. So if you don't work, you can't really apply for this, basically some exception. But if you earn 15,000 at least a year, up to a plateau, you can earn up to 7,000 almost per household. And then Michigan raised, so the state of Michigan matched this federal money, so you can get up to 30% extra. So it's a lot of money. And when we had, when we looked in the group before this project, all over Michigan, 45% had heard about EITC, but only 26% had claimed it. And that was the entire population. Now we looked at the vulnerable group that had much less knowledge about this. And we went and there's a Accounting Society of America. So we work with women and infant children, which is child care and pregnancy care. And you can stay there for some time after, after the child is around 5 years or something. And since there are more than one child typically in this household, you can stay there for quite a long time. So that was where we recruited mothers who wanted to be part of the study. And then we worked with the American Accounting Society, which is a free organization all over America who helps people file taxes. And that's critical. If you don't file taxes, you can't apply for this money. You can't get earned income taxes. So we worked with them too. But the women, infant, children, WIC, where the care was provided to mothers and kids, that's our base. That's where we kept the recruitment. We followed up people, etc. And we discussed a lot, what should the message be? How should you communicate this message in a way that makes it attractive? And the Accounting Society of America had a lot of good ideas, and the community had a lot of ideas. So we came up with slogans like that, right? Keep more money in your pocket for the important things. And file your taxes and get the claims. And then we had big billboards all over this area to advertise that, hey guys, there's money here. Go for this. If you're eligible, do contact this person, reach out, or this organization, reach out. So all over Michigan have this. We did a lot of, we did some flyers, and it was a randomization that was in this. So first we tried to bombard social media, billboards, influencers, all that kind of information to get out there. But then we also randomized, so half the group at Women, Infant, Children got a brochure, and the other half didn't get one, because we thought if you give a brochure on top of everything, maybe you have a bigger uptake. It was all in English and Arabic, and you could see exactly how much money, if you have 3 or more children, single, you make 50 to 60, or if you marry 56,000, you can get $6,600 plus the 30% from the state. So people could see, okay, what's in it for me? And here is the tax appointment, where people help you to fill out the tax form. Hands-on, free, no charge. The challenge is to schedule when people can come, and a lot of this was also done during COVID. So we just completed this study last year. So it all was done online. And then here we looked at engagement. How much did people engage with the message on social media? So we knew exposure, right? How much exposure did this program have? So we tried to track that and compare to benchmark. Are they staying on the page longer than a typical? For example, average unique visitor for a typical site was 750. We had over 2,000. Average attention span, you look how brief it is, 55 seconds, 35 seconds. That's the average time you spend. So you need to get people to stay on, right? Click through, 2%. So if you go in on the site, and okay, whatever it says, if you click on the site, right, which is a good site, you go to next step, It's only 2% who does that. And this, this is what they, in marketing, they really look at, unless we, you're not going to have any sales. And then average scroll depth is how deep do people go? How many levels do you go down in information? 50%. So it's very similar. So we compared well or better, equal or better to the benchmark that we benchmark against. Then you can see what happens here. We are talking about information. You can see how that it's the top. It increases the knowledge on the search, and then you can see how it goes down once the information is not online anymore. We don't push it. So this is kind of, we try to understand the exposure. Does the community actually get any information? And this is everything we did. We did, 33,000 Facebooks, we did 1,000 flyers, 11 billboards. So it's a huge amount of effort together with the community to get the message out. And this is the study population, and you can see the grouping who took part of it. And we said it was Arab American, it was Canadian, and then a lot of overlap. MENA region or Middle East region in this case. And you can see also most were married, etc. And educational level here, there is some people have quite, way above college or above. And there's a lot of people who didn't had very little education. It was a big span. Remember, this program is only based on income. So it's not based on anything else. It's the income and number of kids in the household that drives. So you really have to target information that suits a lot of different kind of skills level or training level. And employment was 12%, and further some 5%. So most people were unemployed. 81% of this group was unemployed. So once again, they also work with employment program, this organization, and that's a whole separate thing from this program. But at baseline, most people were unemployed. And this is, it's really hard to recruit. It's really hard to keep people in this kind of studies. And we followed for 1 year. So at baseline, we had 215 people. After 1 year, we had 155. And after half year, sorry. After 1 year, we had 100. So we lost a little bit, around half we lost to follow up. And then we compared, there's no number of responses, whether you took part in 1 or 3 studies, survey responses, had no relation to earning knowledge of EITC, and no relation to health, and no relation to wellness. But the people responded to all surveys versus fewer. So those who responded to more surveys, they were more worried for paying mortgage and rent. That was the only difference. So those who responded were more worried. Do I have enough money to pay for my mortgage next month or my rent? So it didn't seem like, and we've seen that in other studies too, it doesn't seem like there's a bias or a response bias who continue to respond to these questions or not. And here is the 61% at baseline was not worried about paying for, in this case they had paying for rent, and the next one you had paying for nutritious food. Do you have enough money to buy nutritious food to your family? There's a lot of people who are worried about it, right? Look, it's like here's 24% who are worried about having enough money to buy nutritious food for the family. And here is we're trying to see, okay, can we actually increase the awareness of the information campaign? So we had a lot of indicators. Have you heard about this campaign? So we asked, key question: have you seen the billboard? Have they heard it on Facebook or social media, etc.? Have you seen the brochure? And you can see in this first cohort was very few people have heard about it, 10%. Second cohort with non-flyer was up to 40%, and with no difference really if you use the flyer or not, which it should be. We randomize it. It should be. This is the baseline. And then the last cohort, it was around the same. So it went from 10% to something with 30-40% knowledge. And we had done a massive outreach. We really tried to plaster the whole community with this kind of information using a lot of different outlets. And we still had, we could say this is great, significant increase. You could say, all right, so a lot of people still hasn't gotten information. And then in EITC, uptake increased. And they call it uptake, that's do you claim EITC? And that's of course what we want. We just don't want knowledge. We want also that people should claim it. You can see it's a slight increase here over time, but still very low, right? So when they model this, and the national modeling is modeled on that 85% takes up EITC. But it's not based on EITC, it's based on similar programs in 2 cities. So the uptake is much, much lower, especially among underrepresented groups. And here is what happened with employment at baseline. So at baseline, we had 30 people employed. And then at follow-up, you could see we had like, I think 18 or something employed. But still, there's a high rate of unemployment still that follow up. There's significant increase in employment, but it's such a small numbers. So it's still a challenge. It's not enough just to have the program. You have to work with other interventions too. And here is campaign awareness scores. So we created scores. Have you heard about it here? Have you heard about it here, etc. And you can see how it goes up from 0.1 to this level. But it's still extremely small. It's 0.6 and the scale can go up to 2. So it's it's a lot of, even though we did all this, we engaged the community and everything, you can argue that there must be a way. And we were among the best, I think, in the whole, it's group 15 around the country. But there's so much more we can do to get this information out. Okay, so what are some of the findings? So we looked at halftime. How worried are you for paying rent? How worried are you for buying nutritious food? Halftime. And then we tried to predict what impact does that have for health. So this is baseline. We controlled them for baseline health. And what is your health then 1 year forward? And you can see that if you worry about paying for meals, and that's yes, I'm worried, I'm not worried. We have 3 categories of worry, but we compared no worries with any degree of worries. You can see that worry lowers on the scale of 0 to 10, 0.74. So this and explain 5.6% of the variance in health. And health is extremely important variable. It's predictive. So if you ask me, how do you feel today? If I say I feel, good, really good, I'm 5 times more likely to be alive and healthy 8 years from now, 10 years from now, than someone who says, I feel pretty bad or lower. And we looked at that with biomarkers. You can see biomarkers are related to how you rate your self-rated health. And no one knows, but self-rated health is probably one of the best predictors how you're going to feel, how you're going to fare in the future. Predicts mortality and morbidity. No one quite knows why, but it's a tremendous, just listening to your body, right? Again, that's something you can do in the community. You can ask the community self-rated health. It's really one of the most strongly predicted variables, super simple. But anyway, so your health is lower if you're worried about paying for meals. And if your energy is also lower. Energy is, how would you rate your overall energy? And the lower the energy is, the harder it is to control your bad habits, right? Impulse control everything. If you're tired, you tend to eat a little bit more, maybe drink more coffee, etc. Drink more soda. So it's the brain, it takes a lot of energy for the brain to use the executive capacity at the right level. A lot of energy. So that is higher for people who don't worry than for people who worry. And then we looked at mortgage rent, if you're worried or not, and you sleep worse if you're worried for your mortgage and rent. So 6 months, if you're at midpoint, or if you're worried, you're more likely to score lower in health at 1 year, adjusting for the rating at baseline. So we see a relationship between how you rate your, how you perceive about your, basic economics. Can you pay for food? Can you pay for your household? Has direct bearing on your perception or your ratings of health. And then we did, together with Eamon Arbel, who is an expert on structural equation modeling, we tried to understand, okay, is this a mediator? And we find that if you take up EITC, if you claim this money, EITC, versus if you don't claim, it's going to be mediated via not worrying so much for paying for nutritious need on health. So this thing we showed you that you score lower on health if you're worried, it seems that mediates the effect on EITC. So EITC claiming this money to the household does decrease worry, and that does have a direct effect on health. And we can see the same for nutritious meal and energy. And energy is, we have seen biomarkers. You can measure anti-inflammatory markers. The higher you have energy you have in your body, the more you have of interleukin-10, which is an anti-inflammatory. It's a positive inflammatory marker. So this is biologically validated. So, but once again, you can ask people. A lot of these things you can ask. We have already validated, other people have validated. So you don't need to necessarily, you can trust this outcome. Now you have to figure out why. Why is this relationship? But just know this relationship says that in intervention, you have to work on increasing uptake of EITC. Then you can have biomarkers or whatever. We all have different interests together with the community. So that's the first one. And then I'm going to go to another. So basically, that study showed that there are resources available, but the distrust in the government is so enormous, immense. All the lack of knowledge is so immense. So the majority doesn't claim these rights, and which is they have the right to it. So engaging the community, engaging the American Accounting Society, who does this voluntarily, access the Islamic Center, healthcare center, engaging a lot of people, were able to make people aware of this, and we were able to increase the number of people that claim the ITC. But majority is still not claiming it. So it's an enormous, you can say, okay, we had a significant increase, but if you look at this number, there's so much untapped opportunity. And the community keep working with that now. We learn a lot, and the community is now working to reach out with this information to really make sure people. It was an interesting project because we worked with 15 or 20 projects around the country. We met like every third month to exchange ideas, what to experience, what do we learn from one another. So it was a really big learning project also. The other one I'm going to see then is the air pollution, which also is a big killer. Air pollution kills millions of people per year. Killing, I'm now talking about the brain. It creates tremendous effect on the brain too. Inflammatory responses is connected with learning. People are exposed to air pollution from cars, for example, at a group level. They are likely to achieve less income over their lifetime, more likely to be sick. At the old age, they're more likely to have Alzheimer, dementia, etc. So we must now recognize all of this inflammation from PM 2.5, etc. It really gets far down into your vessels, and the body reacts by inflammation. Very, very. And you can see that the numbers are important, a huge amount. So trying to deal with air pollution is important. And this is a group that we worked with. What we did was that we used really advanced chemistry. So we have one person here, Marushita. She can see where the particles come from. We collected particles out in the community, and then we analyzed where is this particles coming from. So we could saw it was coming from Indiana, which had a big, steel plants, from cars, because each particle have like a chemical mark. It's like a DNA, yeah. So it's really fascinating. You can actually see where it's coming from and how it affects. And then we worked with Michigan Department of Environmental Quality. They have an air quality division. They have their own measurement of air quality. And then this is just what the kind of machine we use. So my interest was engaged in the community, but then we took the opportunity to really apply really advanced machinery. And both, we looked at lung function, but we also looked at air pollution characteristics. And this is Malmö versus Detroit. And it's 5 microgram. This is the limit. Okay, big PM is the smallest particles, and we get more and more worried about it because it comes further into the body. It depends, the protection system we have in the lung doesn't work. It penetrates that. And this is Malmö. It's supposed to be around 5, and people are discussing. They want to lower it lower, but Malmö has around 1.2 times the recommended level, so they consider yellow or green. They're not quite green. And here is Detroit, who has twice as much, 2 times 6 of the. They have 13 versus 6 side. Malmö today is like 7.1. So it's still above that cutoff level. But of course, as you know, there is no cutoff. There's no safe level of PM 2.5. But Detroit is even worse. It's twice as much, and we have here is 13. And this is the study that we did. And you can see here asthma. Remember now, this is BM Canada down here, and this is Detroit. And look at the yellow and so on. When you look at this yellow, you can't use the same yellow for Canada and Detroit. So yellow in Canada is 1 per 1,000 population. Yellow in Detroit is 10 asthma per 1,000, 10 times as much. But look at this. Look at close to the industrial and the highways. A huge, the biggest transport, the biggest connection between Canada and United States is in Detroit. The truck there is unbelievable. The number of trucks passing over every day, and it's going through red line neighborhood that get exposed to these diesel particles. And look at the asthma rates. It's just phenomenal. And you can compare that to further away. So it's a real problem with asthma, childhood asthma and adult asthma. And here we looked at, I'm not going to go into detail, but we can see where the wind comes in the summer. Here's the summer where the wind mostly comes from southeast, and in the winter comes from the west, right? And you can see particles. So this is the concentration of PM 2.5. So it's from 20 down to nothing. And you can see here where those particles are coming from. So here it's like almost 15, I think. And most of those particles coming from the south. So you can target. And we also know how much is from trucks, how much is from plants, etc., power plants or steel plants, etc. So this is kind of information we fed back and we discussed with the community. What can you do? What kind of information? How, for example, they're addressing then the depot around the truck depot. They had this idea: can we move the truck depot? And that also become a conflict in the community, right? Because there are community member who works there and makes money, they're living on it. So can you generate better fuel, green fuel, healthier diesel, etc. And then we looked at lung functions, and I'm not going to go into detail, but we really want to understand objective measure of lung function and subjective or perceived. And we looked at, here's the distribution between kids and older persons. And we followed them for twice over a year. And we were interested to see, the income here. You can see 120,000 household income, 27% among the kids, 90. But very hard, and I think we heard this through a week also, very hard. A lot of people don't really know their income or they don't want to report it. And we heard, Rathin this morning that some people work without really officially declaring the income. And if you make too much money, a lot of support system is going to affect you. You're not going to be able to claim as much money. That's why I like EITC, because it's less damaging. If you work at this for $15,000, you will be able to claim EITC. And here you can see, school employment. 93% of the kids went to school. 30% of the older people had a job. So it's still high level of unemployment, even if you adjust for that, the age distribution here. And you can see a number of immigrants in different population, much more immigrants supported along the border, and then kind of insurance. So Medicaid was the most common for people with limited resources. And no insurance was 5% among the kids and 11%. But there was no difference among young and old population. And then we looked at, how many people felt like the air limited their ability to live. Right? We heard that on this IDF function, classification of function. Here's people perceiving, they all have asthma, right? But perceiving that their day is affected by the asthma because of air pollution. Look, it's a huge number. So you still have which I thought was fascinating presentation, same ICD code, but the function. Think how many people here don't function. Perceive they don't function because of asthma. It was more among kids. Here is, we looked at healthcare consumption by season. And for example, visit to one's provider. You can see how that goes up. It was much higher among the older people. There was some differences between seasons, But the biggest difference was between older people had more healthcare consumption, of course, than younger. But there was some difference between the winter and the summer. The theory we had is that in the winter, you spend more time indoors, sometimes very poor environments, but it wasn't that impactful. And then here we can see, respiratory function. So if you look at the ability of the lung to get out air in a short time, it's much higher among the young people than the old. But you also see an effect by season. And this one, if you look at this measure, FEV1, how much air you can get out in 1 second, it's very, very good correlation. It's 0.82. So if you test the person in the summer, it correlates really well with what you see in the winter, which is important to start with. But if you look at this one, compared to how much your lung capacity you have, how much of the total air you have in your lung can you breathe out, it's much harder. It doesn't have the same correlation between the summer and winter. So that affects also interpretation. So we focus a lot on this and on FEV1. And, then we looked at, here is environmental predictors of respiratory health, right? So with shortness of breath, a huge problem, right? A lot of people suffer from shortness of breath. Sometimes we don't really know what it's due to. It's probably totally inside from psychosocial factor, air pollution has happened. But shortness of breath, it's mean 6-month concentration of PM2, 2.5. So the higher level you have with that, the more likely you are to report shortness of breath. So there's clear association between how much air pollution you're exposed to and how you rate your shortness of breath. Once again, these are kind of tools we could use then when we look at this. We don't need to use all these complicated measures necessarily. And here is self-rated respiratory health, baseline environmental exposure scale. We asked them we had people home in each home, and we rated the environment together with a household person. And the worse that environment was, if you saw mold, if you saw leakage, poor heating system, etc., you got a score. The higher that score was of your perceived home environment, the lower was self-rated health. So once again, you have associations, right, between your perceived environment and the way you rate your overall health. And this is something we started, that didn't exist before. Self-rated health is really old, everybody uses that. But we figured it's so complicated how you rate your breathing. So let's see if breath is also relating to environmental exposure. And it is. And then here is how you rate your respiratory health. The better that is, the higher you rate your self-rated health. And as mentioned before, self-rated health is so validated to predict future mortality and morbidity. The lower that is, the more likely you are to develop the disease. So you can see that respiratory system is so important, and it depends on so many factors. I integrate cardiovascular, the lung function, ability to have enough oxygenation in breath and air in the blood, etc. And here we looked at use of asthma control drugs. So air pollution predicted how much of asthma controlling drugs you took, the drugs that controls your asthma. So the more you were exposed to air pollution, the more drugs you took, the air asthma controlling drugs you took. And as you can see here also total healthcare utilization. So more exposure, more healthcare utilization. We know this. It's intuitively known, right? But here you can show it. And then if the environmental score improved, if the scores of the environment improved because of intervention during the 6 months, you also saw improvement in asthma triggers. So there were less triggers of asthma. And so if we improved environment from different kind of community intervention in the home, you saw less healthcare consumption too. So at least that shows there's some kind of causal relationship. And no, I'm going to wrap up now, but this is what we're doing today. This is my work with the community. This is a US 131. This is a highway going right through Grand Rapids, the city in Western Michigan where we live. And in the 60s, they opened this up. Everybody was super proud. But they went right through red line district, and districts that had been short to classify as less likely, less reliable to get loans from. Therefore, the community had much harder time to keep up the housing and etc. But it was a very functional community, very coherent. But it was the cheapest place to buy up. So they built this highway right through. And here, as you can see, how it's destroyed. And it goes like this in the city, and then it's an S curve, and then they continue, because it's all completely built where's the cheapest property, where could they exploit the cheapest property. So now we work with we have 4 different neighborhood associations. We have a really amazing citizen architect who works in the private sector, but together with the community, and we had to redesign, right? It's 140,000 cars per day today. Only 50,000 visits Grand Rapids. And there aren't highways around. You can drive around far away from the city, but no one does. And this is how they envision it. They envision that this elevated highway, you can green it, you can plant trees. And now they want to rebuild this highway. So we have mobilized, or the community has mobilized to fight Michigan Department of Transportation. And they're very skilled, they're amazing, they're really skilled, they have all these meetings. But we have private sector with us who knows how to measure air pollution, we have community organizer, we have the Department of Public Health. We're trying to build a counter vision. Instead of just fighting this, we tell them, look, what could be, what could come out of this? This is our vision from the community. And it's an uphill battle, I must say that, I'm sure. But the idea is that the community has a very clear vision of what could be and mobilize around this. So we're trying to get funding for the Inflation Reduction Act. There's a lot of this green money in there to work with the community. So that's the conclusion. I would say that these psychosocial factors, as well as environmental factors, I talked about financial insecurity and air pollution, has an effect on the brain. And that's going to have long-term consequences about reaching your potential, right? Full potential. So I think, you can do a lot of kind of intervention, but I think realizing that this kind of environment has an effect that impacts learning and impacts ability to learn full potential. We know the association with socioeconomic and lifetime income, etc. A lot of even randomized studies, if you do better neighborhoods, more resource neighborhood, you do better. But of course, what you want to do is improve the neighborhood you live in. So that's the kind of things I think is really meaningful. It's wonderful to work with the community. It's complicated, right? I mean, study like this EITC takes 4 years. It looks simple, but you all know how difficult, how important it is to engage the community, and also make the trust is such an important part. So, thank you.
Thank you so much, Bengt. And we have time for a few questions. Anyone that wants to start?
Yes.
So, Arnetz from Technological Monterrey, you mentioned that you followed some biomarkers, but I wonder if you could elaborate a little bit more what sort of biomarkers you follow and what are the methodologies you use to follow those.
Right, right. Yeah. So in this specific one, the only bio now was lung function.
Right.
But what typically in other studies in this environment, we follow inflammatory markers in blood or saliva.
Oh.
So you can do this like 2 or 3 simple measure in interleukin 6 or interleukin 1,
Yeah.
and C-reactive protein. And C-reactive protein is like everything activates in the body. At the end of the day, you're going to have an increase in CRP, right? You have inflammation. So that's a great marker. And then we look at anti-stress hormone, the androstenedione, which is basically I call it androgenic or anabolic. It builds up resources. Basically, people take this to prevent aging or build muscles. But for the body, it protects the brain. So the more cortisol you secrete, which you can measure in the saliva, the more DHA you secrete to protect the brain cells.
So, and for instance, when you were talking about stress and the impact it has on the brain, and especially focus on children and people in general, have you been able to link any particular sort of stress or like stress in general, like neurodevelopmental issues, like people going into the autism spectrum or something like that?
Yeah, the last thing you mentioned are starting to be linked to environmental exposure, and
Yes.
you have all these neurobiological disruptors, right?
Mm-hmm.
Which we heard about yesterday, and when it came to Menarche. So yes, but I don't think, that kind of refinement I haven't seen. I have seen you measure only PM 2.5, right? But then if we get all the other exposure that occurs, it's not independent, right? So it's a good question, but no. We try to do, in this one, we try to measure perception of the whole environment, it's a measure of the real environment and then psychosocial factors. But you know, it's you can refine it much more than we did, and still we refined it.
I totally understand. Thank you.
Yeah, thank you.
Any more questions?
I'll leave the microphone. You know, Kamala Harris talks about the child tax credit.
Yeah.
Saying, is that thing that you're talking about?
No.
Or is it similar enough that it could be comparable?
Dude, there's money on the table people don't claim. This money exists in the budget. And all disagree, maybe no one fights this money. Tax credit, childhood tax credit, they're fighting, aren't they? These people haven't challenged. It started at 74 something temporarily. Now it's grown every year. It's been huge support for it. Of course, one side believes it because it's social program. The other side believes it because it's pro-employment. So it's a win-win. The childhood tax went away after COVID. Took it away. Yeah. So I rather work with this because I'm not going to have so much resistance. Here I can work regardless of your political view. I can argue, why is so much money unclaimed? Why do you leave it on the table? Yeah. I think this is just $6,000. You can make more money here. You can make $8,000-9,000. Yeah, I don't know why. I'm not sure why this is not being discussed. I'm super surprised. It's like,
Anything more? Did you, Michael? Last question.
Thank you. It's been fantastic. Can you say a little bit about what part of addiction plays in stress? I mean, not as a consequence, but in terms of basically addiction to stress.
Yeah, I was thinking about it. It's good. Yeah, that's a problem. That is, you're right, about feeling good, feeling high. Yeah, cortisol is a great hormone. It makes you really feel good for short term. Yeah, and you know, some people haven't slept all night. You can either completely fall apart. Other people feel really high until they crash. So you're right. A lot of this, the brain really likes. You know, that's what they learn with all this kind of. You know, we completely hook to the the Facebook and WhatsApp, etc. It triggers the brain. Yeah, and it becomes an addiction that way. And you can measure that very much. And I think, you know, that's why that's the problem with real addiction, because some people say they don't get that feeling of a kick. If they had to do something like, they give them a real kick, it can be different kind of activities. They don't get that same kick unless they do that, or when they take some drugs. So, you know, the brain is really, that's what's so hard. You trigger this kind of, really, you feel great, short term, you know, with stress.
So I have a question. In the slide that you showed, it indicated the lower rates of those who were eligible, right?
Yes.
It's down by race or city.
Yeah.
So do you account for both parents in that group? Because in the US, to earn the credit, only one parent is eligible.
Yeah.
So if you're not accounting for that, then that's going to contribute to the low rates.
Yes, and you know, I can't answer that because that's published data, but we see it when we looked at our data. We see it.
Okay.
Yeah.
Because obviously it would.
Yeah.
But really, it's one unit, right?
Yeah. Family, you're right. But and you know, I must say, it took me a long time to understand EIPC. Fortunately, we work with this is I don't know what I tried to read it. I'm not a lawyer, but you know, we had lawyers with us to explain it. Earned income tax credit. It's very complicated, and we're fortunate to have, you know, American Accounting Society with us, who they are completely dedicated to working with the community. But these are super complex things, and I know maybe the top of it, but I know enough to this. But we have those people with us, you know, they're with us as a team.
But we also know in the US that there's a lot of single parenting happening. So also one of the regulations is that that child must live with you
Yeah.
at least 6 months. So a lot of people, even though they're, and I know it was published data,
Yeah,
but even though they're quote unquote eligible, they're not really eligible
No.
because the child is not living with them and
Yeah.
cannot document that.
right. No, I agree, And homelessness, for example, you don't, it's so much tragedy behind these numbers, you know, and it's a lot of trauma behind this. Yeah, absolutely. And I don't want to go into that in detail, but you're right. And that's why you need to work with pros, you know, all these kind of, you know about it, you're an expert, but you know, it's for a typical researcher, it's, I need to work, I need to bring these people into the team so we understood it. Yes.
Okay, your last question.
My question is, the neurobiological behavioral choices and the impact of the brain when we talk about prenatal and then relearning of the brain.
Yeah.
Have you looked at how it impacts some of these children when it comes to abiding to rules and regulations in society, anything leading to deviant behavior?
Yes.
And when we look at that, how our judicial system punishes some of this deviant behavior, whereas if you try and understand that the person is predisposed from the beginning
Yeah.
because of distress.
Yeah. I agree. It's like you prime the body during pregnancy, or that's, you know, that hypothesis, and then you have this exposure. I think that's what Mike was touching on also. It's exciting probably to be in a gang. You know, short term, right? And very exciting. You have this hierarchy and everything. That's something I would like to pursue. That's one of, you know, what is the implication for this kind of, what kind of countermeasure can you do? But, you know, unfortunately, we did this way back in Detroit, and we brought together people. One was a judge, and he said, I'm so sad, you know, I see these guys in family court, 20 years, 30 years old. Then they come back to me, no, 10 years old. They have issue with the school, but they're too young to be punished. Then they come back to me at 17 or 16, and then bad things happen. I have to put them in jail. And what are people doing? Why isn't the school system doing something? And he was really frustrated. But I think you're right. I think we need to understand that much more, right? That you have primed the body, you have primed. So this environment around gangs can be very rewarding short term. Yeah, but we haven't done anything on it yet. But it's an area I really would like to target because it's such a concern. The Swedish, it's American, I don't know in Denmark, but Swedish is now to punish for the dawn. You know, the younger, I mean, the lower the age, where you have significant consequences for doing something crime related. And it's very little, I think what they do here in Malmö could have tremendous impact on these things, you know, to look at it more ecologically.
Okay, thank you so much, Ben.
Yeah.
Thank you.
Thank you so much. Thanks. That was good. I lost that. Didn't you?
Vad är det då?
Ja, nej, jag behöver på lite grann så här. Det kanske. Ja.
Sorry.